This is Randy Schell, and I'm making a podcast entitled Aging, Physiology, and Pharmacology. This is part of the University of Kentucky College of Medicine, Department of Anesthesiology, Educational Didactic Podcast Series. For many, the topic of aging, physiology, and pharmacology may be a little bit like me trying to sell you liver and onions. However, if you look at the ABA ITE keywords related to this topic of aging physiology, you can see there's quite a few on cardiovascular physiology and aging, respiratory physiology and aging, autonomic physiology and aging, and then some on the changes that occur pharmacologically, pharmacodynamic, and pharmacokinetically with aging. So under cardiovascular physiology and aging, you can see LV function, diastolic and systolic function, SVR changes with aging. Under autonomic physiology, changes in autonomic function, baroreceptor dysfunction. Under respiratory physiology, pulmonary physiologic changes, hypoxemia related to an increase in closing capacity. Most of the questions appear to center around that. And the decrease in arterial oxygenation that occurs with aging. And then the pharmacologic changes, including a requirement for reducing opioid doses, very little change in muscle relaxant dosing, a decrease in most of our induction agent dosing, and definitely a reduction in MAC with our inhaled volatile anesthetics that occurs with aging. So let's start right in talking about aging, physiology, and pharmacology. We'll first talk about the physiologic changes with aging and try to provide some select clinical correlations between those aging changes and what we do clinically. We'll talk about some pharmacologic changes with aging and some clinical anesthetic considerations for providing anesthesia for the elderly patient. It's pretty evident that the number of older Americans is increasing in the United States, and if you look at the current population percentage above 65 years old, it's approximately 12%. And if you look at the graphic to the far right, you can see that projections are up into the 20+% range by 2050. And if you look at the relative per capita health spending by age in the other graphic on the bottom left, you can see that as we age, more money is spent on healthcare costs. If you look at perioperative services, there's an increased number of surgical procedures as aging occurs. And if you look at the Medicare patient data, it's sobering to see that 40% of elderly patients suffer minor or major medical, surgical, or anesthesia-related complications during hospitalization for non-cardiac surgery. There's a relatively high incidence of failure to rescue events that occur in the aged patient, and 4% die in the perioperative period. So we need to know as much as we can about the physiologic changes of aging and how it impacts our anesthetic care. The first thing to think about is the declines in physical status that occur with aging. Is it chronologic or biologic? In other words, is it just how many years old you are, or is it your biologic age? We all know 80-year-olds that have the biologic age of a 40-year-old and chronologically aged 40-year-olds that have the body of an 80-year-old. Lifestyle habits, diet, psychosocial factors all impact the age-related physiologic decline that we see in most of our organs, and the lack of functional reserve that is present so that when those organs are stressed, they cannot increase their function. So there's little correlation between true chronologic age and biologic age, and we need to consider each organ system and how it's functioning in each patient. If we look at organ function on the y-axis, 0 to 100%, and age on the x-axis, you can see that organ function is maximal over a wide time that we are aging, but then it starts to fall off. And as that organ function falls off, you can still see it significantly above the basal rate, and there's still a good functional reserve, but at some point that functional reserve gets less and less, and when you stress that elderly patient, they may not be able to crank up the heart rate, the cardiac output, the stroke volume, the minute ventilation, etc., to meet some of the stresses that may occur in the perioperative period. Age and anesthetic risk. Advanced age is consistent risk for morbidity and mortality associated with anesthesia. And we all know that chronic diseases tend to increase as we age. Diabetes, hypertension, COPD, etc. And that there is increased risk of surgery when there's lots of coexisting diseases. ASA physical status is one thing that we try to utilize to identify coexisting diseases. But there's no evidence that age by itself increases perioperative risk in the absence of comorbid conditions. So it's those coexisting diseases that we need to identify and optimize in the patients coming to us, including the elderly. If we look at percent change associated with age on the y-axis and age on the x-axis and showing many different physiologic changes, you can see our basal metabolic rate decreases, our maximal heart rate decreases. In fact, 220 minus your age is approximately your maximal heart rate, which I discovered years ago riding my spin bike and realizing I can no longer get my heart rate up over 200. In fact, my maximal heart rate now is approximately 170. Our muscle strength goes down, our bone mass goes down, our maximal cardiac output goes down, although our baseline stays the same. There's a little change in ejection fraction or cardiac output at baseline in a healthy patient, but the ability to maximally crank up our cardiac output to meet stresses, can't do it as much as we age. Same thing with our vital capacity and our oxygen use by our body. Our blood pressure tends to go up, systolic especially, and isolated systolic hypertension of the elderly is not uncommon, and our heart weight goes up. So let's start with cardiovascular changes with aging. It's important to separate out the cardiovascular effects of aging in and of itself versus common coexisting cardiovascular diseases like atherosclerosis, hypertension, diabetes, atrial fibrillation, aortic sclerosis, etc. And there is an increased prevalence of cardiovascular disease with age. The major changes, however, can be these four here. The first is there's a decreased response to beta receptor stimulation. So if you give a beta receptor agonist to an elderly patient, you don't expect to get the same response of, for example, increase in cardiac output to the same dose. The myocardium gets stiff, so diastolic dysfunction, the veins get stiff, and the arteries especially get stiff with the vascular resistance going up, the afterload going up, and systolic hypertension frequently occurring. The autonomic nervous system responds with increasing norepinephrine levels circulating in an elderly patient, and actually heart rate, resting heart rate that is, tends to decrease, and maximal heart rate definitely decreases with time. And there are some conduction changes in the heart itself. So graphically, if we look at this, our VO2 max, our ability to use oxygen goes down. Cardiac output at baseline tends to be normal, but as you stress the patient and increase demands, they cannot meet the same increase in cardiac output that a younger person could. Heart tends to get a little bigger with increase in cardiothoracic ratio on X-ray. Maximal heart rate goes down, resting heart rate tends to go down, systolic blood pressure goes up, the heart tends to get a little thick from the increased afterload, and oftentimes the heart is not or does not have the ability to relax like it has in the past, i.e. diastolic dysfunction. Left atrial pressures may go up, and atrial fibrillation commonly occurs in the elderly. Let's focus in on cardiovascular changes related to the beta receptors. Up at the top graphic shows norepinephrine fitting into a beta-1 or beta-2 receptor, and chronotropy or heart rate, dromotropy being conduction, inotropy being contraction basically, and lusotropy being relaxation. Some of the things that occur when beta agonists bind to beta-1 and beta-2 receptors. There's a decrease in the response to beta receptor stimulation. So we tend not to think of there being a change in the receptor number, but that just those receptors don't work as good. So there's a problem with intercellular coupling, and they don't respond to endogenous circulating norepinephrine and exogenous, for example, dobutamine that you might administer intravenously, drugs that have beta effects. So clinically, we see increased circulating norepinephrine levels when increased myocardial flow demand is required. can't increase the heart rate as much. Venous return doesn't go up as much because the veins are stiff and don't contract as much to push more blood back to the heart. And systolic blood pressure at rest is often high. There tends to be a decreased response to stress and exercise, with maximal heart rate being decreased, decreased peak ejection fraction, and there's a tendency to meet and increase cardiac output demand by increasing preload. In other words, filling the heart more, increased end diastolic volume, which can make the heart more susceptible to cardiac failure, and we'll talk a little bit more about that in several more slides. So, cardiovascular changes other than beta receptors, the next one is stiffening. Stiffening of the arteries, stiffening of the veins, stiffening of the heart itself. The arteries stiffen and systolic hypertension occurs. The veins can stiffen and ineffective maintenance of preload can occur, and that is the veins are reservoirs for our blood and can buffer changes in blood volume. Normally, if we need volume to our heart, the veins can constrict quickly and provide preload. Phenylephrine administration, that's one of the things that it does. Alpha agonism constricts the veins, also the arterioles, but the veins, and preload goes up. This increased afterload, or SVR, can lead to LV hypertrophy, increased size and thickness of the heart, but usually systolic function is preserved. You do an echo on an elderly patient, their EF 60-65%, and you feel good until you realize, why do they have heart failure? They have heart failure because of maybe diastolic dysfunction. And the heart tends to be stiff, increased connective tissue, hypertrophy, and decreased diastolic compliance. With that heart being stiff, the elderly become very dependent on the atrial kick for filling. If you have an elderly patient who's in sinus rhythm, who goes into a junctional rhythm after you put them off to sleep and lose the atrial kick, they can become very hypotensive. Instead of just 25, maybe 30% of the LV filling being due to atrial kick, it may be 50% or more. They need time for filling of the left ventricle, so tachycardia, very high heart rates, are poorly tolerated. And if you pour in fluids to these patients, you can easily precipitate congestive heart failure. So summarized again, their peak heart rate is down, their maximal oxygen use is down, they can't increase their ejection fraction as much, so how do they increase their cardiac output when needed, stress during surgery? And they do that by increasing their stroke volume, by increasing their end diastolic volume. So their hearts are operating from higher volumes in an attempt to get more output, and that's the way they maintain cardiac output as opposed to the young. There tends to be impaired diastolic relaxation in the aged heart. This is demonstrated here in the graphic, which we'll go through. In a patient with decreased lusitropy or relaxation or diastolic dysfunction, the heart is stiff, does not relax as well. The pressure in the heart during diastole goes up. As LV-EDP goes up, diastolic pressure in the heart, that's transmitted back through the open mitral valve to the left atrium and into the pulmonary vasculature. Pulmonary hypertension, left atrial enlargement, atrial fibrillation, all consequences potentially of poor diastolic relaxation of the aged heart. And some of these patients will come in heart failure, and you do echocardiography on them and see a normal ejection fraction, but then when you look at lusitropic function, you see diastolic relaxation issues. In these patients, beta blockers and calcium channel blockers are the treatment rather than the classic use of, for example, Lasix in a patient with systolic heart failure. So when we look at the elderly heart trying to look for diastolic dysfunction, one of the things that's looked at is the pattern of inflow from the left atrium to the left ventricle by Doppler. So I've shown you a graphic of a Doppler signal being sent across the mitral valve, looking at filling patterns of the left ventricle. E represents the passive filling that occurs of the left ventricle when the mitral valve opens, followed by diastasis, followed by the atrial kick in the patient with sinus rhythm, and usually the E wave velocity is higher than the A wave velocity. And in this case, as you age, there can be a reversal of this, and this may be an indicator of diastolic dysfunction. That is a simplistic explanation of using echocardiography to diagnose diastolic dysfunction. In the autonomic nervous system, there are age-related changes also that can be superimposed on cardiovascular disease. Cardiac output tends to be preserved, as mentioned previously, but it's limited in its ability to crank up and produce high cardiac outputs when stressed. In the autonomic nervous system, there tends to be a decrease in resting parasympathetic tone and an increase in resting sympathetic tone, with circulating norepinephrine levels going up. And as previously mentioned, beta-adrenergic receptor responsiveness is decreased, but the number itself does not change per se. Baroreceptors don't work as well, and you probably have seen an elderly patient get up from bed or get up from a sitting position, and they do it very slowly because if they get up rapidly, they can't increase their heart rate, constrict their blood vessels like you can, and compensate for the decrease in blood pressure that can occur and the decrease in volume in your heart as you stand up quickly. There tends to be no change in alpha-adrenergic or muscarinic receptor activity. These autonomic changes lead to a decreased response to perioperative stress and an impaired protective reflexes when a patient becomes hypotensive in the perioperative period. So, looking at the autonomic nervous system first at the top left, end organ responsiveness is decreased, norepinephrine levels are going up, beta agonist actions reduced, so the chronotropic cardiac contraction and vascular relaxation response to beta receptor agonism is reduced. And on the far right, the threshold for activation after input is increased. It takes more so that they are baroreceptor less responsive, so they're not going to vasoconstrict as much to cold. They're not going to have as many beat-to-beat heart rate changes that are normal. We want heart rate variability, for example, with thoracic pressure and volume changes. And so there can be wider swings in hemodynamics, less effective, that elderly patient in maintaining constant organ perfusion during surgery, and you're going to have more intraoperative and postoperative hypothermia. The conduction system of itself, of the heart, also can have changes. The pacemaker cells tend to decrease in the SA node. Sick sinus syndrome is not that uncommon. There can be problems with AV nodal conduction, first and second degree heart block, and there can be conduction bundles infiltrated with fibrous and fatty tissue, leading to something, for example, like right bundle branch block. We previously mentioned AFib as being not that uncommon in elderly patients and an enlarged left atrium, and their left ventricle can also get big. If you see left bundle branch block, though, in a patient, you should not consider that a normal aging finding. Look for evidence of coronary disease, for example. So anesthetic implications, let's put it into context. Identify concomitant cardiovascular diseases in your patient preoperative. Do they have coronary disease? Do they have aortic stenosis? Versus just normal aging changes. 30% of aged patients have an abnormal, that is, 70% have a normal preoperative electrocardiogram. They can have dysrhythmias and conduction abnormalities. Right bundle branch is one that we pointed out. They can have a potentially delayed induction with IV and rapid induction with inhaled agents if their cardiac output is low. Their cardiac reserve is decreased, so they're not going to ramp it up when needed. And they use the Frank-Starling mechanism, increased end diastolic volume, bigger left ventricular volume, when an increase in cardiac output is needed, as opposed to you and I potentially can go up on our heart rate and stroke volume. They use mainly end diastolic volume changes. The compensatory response to low blood pressure, or for example isovolemic hemodilution, their hemoglobin is 7 but their volume is euvolemic, they cannot compensate as much as you or I can, and you may have transfusion triggers higher in those patients. And elderly tend to act like they're beta block, with resting heart rates that are lower and maximal heart rates that are not as high. Isolated systolic hypertension tends to be present. Not uncommon to have an elderly patient with a blood pressure of 160 over 85, for example, and they're not going to respond to catecholamines like a non-aged patient. Let's switch gears now and talk about some respiratory changes with aging. The elderly lung tends to act like a balloon that's lost its ability to collapse back on itself. So a loss in a lung elastic recoil, the lung actually becomes more compliant, almost like a COPD type lung as you get really, really old. The ability to oxygen diffuse is reduced to some extent, and closing capacity increases with aging. It was one of the major reasons why, as closing capacity goes higher and higher and gets closer and closer to FRC and actually crosses FRC at 65 years old in the standing position, you can see why there can be VQ mismatch where the small airways are closing even at FRC levels. VQ mismatch occurs, AA gradient becomes wider, and P little AO2 goes down as we age, so that an 80-year-old may have a PO2 in the 70s, quotes, normally. And the residual volume tends to go up with small airway closure and gas trapping, again, like that COPD patient who has an increased residual volume. Their flow rates may also go down. So if we look at this graphically, this closing volume versus residual volume versus FRC concept, you can see that the closing volume is going up with aging, crossing FRC at about age 65 in a standing position, even in a sitting position, that is. And what this means is that the small airways are closing off, gas is not being exchanged maximally, you're having VQ mismatch, and it contributes to the low PLAO2, or the decrease in PaO2 that occurs as we age. You can see gas trapping as the residual volume is going up, residual volume being the gas that's trapped in the lung at the end of a forced exhalation. Remember, FRC is the gas that is present in the lung at the end of a normal tidal volume breath. So, in summary here, closing volume goes up, FRC may go up a little bit, but they are crossing at age 65, and there's an increase in residual volume. So there's changes in the lung itself, the ventilatory control, the bellows, the conducting airways, and the airway reflexes. In the lung itself, we said it becomes more compliant and less elastic. It doesn't want to collapse on itself. Emphysema-like changes. There's VQ mismatch as the closing capacity goes up, and there's VQ mismatch with decreased PLAO2. There's also a decreased responsiveness to increasing CO2 levels or decreasing PO2 levels, so that the elderly patient will not hyperventilate to the same extent to induced hypercarbia or induced hypoxia like a younger patient. The chest wall compliance is poor as arthritis occurs and cartilaginous changes make it stiffer, and the muscles are not as strong, so the bellows, the respiratory bellows, don't work as well. In the conducting airways, there are minimal changes in the conducting airways, and the airway reflexes themselves may decrease. And the way you may see that is in a elderly patient who you put to sleep and do laryngoscopy and actually see food, their food back in the throat, sitting around the glottic opening. You say, how can they have that there for as long as they've had it there? They've been NPO for 8 hours. Their airway reflexes aren't quite as good. Continuing on with the respiratory system, pointing out again that they have an impaired ventilatory response to hypoxia and hypercapnia. If you add on some opioids and benzodiazepines and inhaled anesthetics, it's going to make it even more a problem, or more impaired. And the VQ mismatch raises the AA gradient, decreases the PaO2, and decreases our effectiveness of pre-oxygenating patients before induction. Some books point out a left shift in oxyhemoglobin dissociation curve, and this was an ITE key word, so I just wanted to point it out that there may be a left shift in the oxyhemoglobin dissociation curve with a decreased P50 as we age. Remember, the very young have a P50, like the neonates in utero have a P50 greater than a normal 27, while that is the maternal P50 is greater than 27. Well, the neonate in utero has a P50 in the teens, so that oxygen has a tendency to go from the mother to the neonate. Well, elderly here, there may be a tendency to hang on to oxygen with a decreased P50 and less delivery to the tissue. Hypoxic pulmonary vasoconstriction is vasoconstriction of the pulmonary vasculature in response to hypoxia. It doesn't work as well in the elderly, and if you're doing one lung ventilation in the elderly, you may have some problems with maintaining your oxygen levels. So some implications of respiratory changes with aging clinically. They're not going to respond to hypercarbia or hypoxia with hyperventilation as much. The respiratory depressant effects of our opioids and benzodiazepines can be very great. So even small doses of midazolam, small doses of fentanyl can get you into respiratory issues. Their maximum expiratory flow rates can be decreased. They're not going to cough as well. Atelectasis is worse, and pneumonia can increase in the postoperative period. You expect the P-LaO2 to be decreased preoperatively from that closing capacity FRC issue and VQ mismatch. And they may require more oxygen supplemental in the recovery room, and we're going to expect some VQ mismatching that worsens when we go supine and put them to sleep and provide positive pressure ventilation. And because their airway reflexes aren't as good, they may be less able to prevent pulmonary aspiration of foreign material. Well, what about the brain in the elderly patient? The graphic at the top right shows percent of control versus age for cerebral blood flow and cerebral metabolism. And you can kind of think, at least it makes sense, that if cortical neuron density is less, you're losing neurons, that your cerebral blood flow would go down because cerebral metabolism also goes down and autoregulation is intact. Atrophy is quite frequent. We see that on CT MRIs of brains, but that does not necessarily correlate with cognitive decline. We do see neuroreceptors and transmitters decrease: serotonin, dopamine, acetylcholine, and you can then understand a little bit why there's an increased sensitivity to many of our anesthetic agents. In fact, MAC is decreased about 6% per decade, such that an 80-year-old may have a 40% or so decrement in MAC. It requires much less desflurane, isoflurane, or sevoflurane. There are problems postoperatively in the central nervous system. One is postoperative cognitive dysfunction, or POCD, which is a persistent deterioration in mental performance, diagnosed with neurocognitive tests. Advanced age is the #1 predictor of postoperative cognitive dysfunction. There's been a lot of study around cardiac surgery and postoperative cognitive dysfunction. If you have long operations in the elderly who have infections or some complications postoperatively, this is a real worrisome issue. Postoperative delirium is a transient issue, fluctuating disturbance of consciousness. We make a clinical diagnosis rather than a cognitive test diagnosis of delirium. It's often on postoperative day 1 through 3 in these elderly patients, and often presents as agitation and sundowning in the nighttime. What about the kidneys? Well, glomeruli go down in number, the length and volume of proximal tubules go down, glomerular filtration rate goes down, tubular function goes down, and if you look at a way to estimate creatinine clearance as 140 minus your age times weight in kilograms over 72 times your serum creatinine, you can see that age is factored into your creatinine clearance. So we have the decreased ability to concentrate and dilute things, impaired handling of sodium and potassium, and ability to excrete hydrogen ion. But if you check a creatinine in an elderly patient, it should be normal without renal dysfunction. If an elderly lady, for example, has a creatinine of 1, 1.1, 1.2, you better worry, because their muscle mass goes down as they age, and that may be a very abnormal creatinine for the amount of muscle mass they have. So be careful in the elderly interpreting creatinine levels that you would normally say to a young person, oh, that's probably normal. 1, 1.1, 1.2, it is normal in a young person. Maybe a patient with a very low GFR if they're elderly. In the liver, hepatic blood flow and liver size tend to go down. We don't produce as much albumin. The ability to oxidize drugs, which is phase 1 metabolism. Remember, phase 2 metabolism tends to be things like adding a molecule of a sugar to that to make it charged and the ability to be excreted. So drugs with high hepatic extraction ratios may increase in their serum concentration. We may not be able to get rid of them. And the maybe a change in free fraction of protein-bound drugs if we don't have as much albumin around. But there's little change in standard liver function tests if you just measure those in an elderly patient. So their PT, INR should be normal unless they're on medications or have very severe liver disease. Thermoregulation and aging. There's greater variability in core temperature. Remember, the autonomic nervous system is not working as well. The ability to vasoconstrict is not as good. So in the perioperative period, if they cannot vasoconstrict in response to cold as a normal patient would, there's a risk for hypothermia. And there's also a risk for hyperthermia because they don't sweat as well, and their threshold for sweating is actually increased. So you can see how problems with cold mainly, but also potentially problems with hyperthermia can occur in the perioperative period. Some factors responsible for this thermal stress responses, which are attenuated in the elderly. From Pharm and Phys and Anesthetic Practice, 4th edition, you can see that the reduced sweat gland output, reduced ability to increase cutaneous blood flow and get rid of heat, reduced ability to crank up their cardiac output and give blood flow to the periphery, there's a loss of muscle mass and reduced ability for cutaneous vasoconstriction in response to cold stress. Lastly, let's finish up with some pharmacologic changes with aging. Our bodies change as we get older in that we lose muscle mass, body fat goes up, and total body water goes down. So if you have an increase in fat and less water, you can see how the volume and distribution of drugs can be changed. Fatty drugs, more fat to go to. Drugs that go to the water space of our body, there's less water space. There's potential alterations in the ability of our liver to chew up drugs. Remember, oxidative metabolism changes, and the ability of our kidneys to get rid of those drugs. Elderly patients tend to be more sensitive to anesthetic agents. That's a pharmacodynamic effect. And they may have pharmacokinetic changes because their liver and kidneys not working as well. One interesting one is that when you give propofol to an elderly patient very rapidly, remember that propofol vasodilates and blocks baroreceptor response. In the elderly patient, they may get very hypotensive if propofol is given rapidly and in large doses because their baroreceptors are already not working very well and they can't vasoconstrict as well. This graphic shows what happens to the fractional composition of our bodies as we age, showing that both men and women, water content goes down and fat goes up, so that we can have changes in serum protein and how much of certain drugs are bound to proteins, we have a reservoir for lipids to go into, and that our total body water is down so that water-soluble drugs such as muscle relaxants have a lower volume of distribution. However, I don't want you to take home the message that there's large changes in muscle relaxant dosing unless there's pharmacokinetic changes, i.e. kidney or hepatic dysfunction. So let's look at the difference between pharmacodynamic versus pharmacokinetic changes in the elderly. The target organ being the brain, increased cerebral sensitivity to propofol and opioids, and benzodiazepines like midazolam, and our volatile agents with MAC reductions. Yes, they are more sensitive to those drugs. No, there's no increased organ sensitivity to neuromuscular blocking agents, etomidate, and barbiturates. And one of the questions that has shown up on keywords in the ITE is from the American Board of Anesthesia is barbiturates. There's no increased organ sensitivity, but we tend to reduce the dose. Why? It's a pharmacokinetic effect, not that the brain is more sensitive. When you give a barbiturate like methotrexate or in the older days thiopental, there was a smaller central volume of distribution, so increased serum levels from a given dose were attained in the target organ, the brain, and more of an effect. But it was not because the brain was more sensitive to that drug. So some summary recommendations for inhaled volatile anesthetics. We're going to not give as much, realizing that MAC is greatly reduced, that induction agent should be reduced, dose 15 to 50%, midazolam 75%, or even avoided if possible. Opioids should be reduced about 50%, including remifentanil, which is broken down by esterases in our body. Neuromuscular blocking agents, it depends. If there's a problem with the kidney or liver, and that's where the neuromuscular blocking agent is mostly cleared from, gotten rid of by, then we should change the dosing. But there's no change with cisatracurium. Probably some benefit to using shorter-acting neuromuscular blocking agents, rocuronium, for example, and avoiding pancuronium. So opioids in the elderly, there's an age-related decrease in pain perception and increased sensitivity to opioids such as morphine, sufentanil, fentanyl, and remifentanil. And you're not going to clear some of those opioids quite as fast. We probably should avoid meperidine. It's not a great drug anyway, but can really cause confusion in the elderly. Remifentanil has increased brain sensitivity like many of those other opioids that we previously mentioned. It's about 2 times as potent. Like most of our opioids, about half the dose is needed to have a similar effect. So one recommendation is half the bolus dose if you're going to bolus it, and use about 1/3 of the infusion rate when you're using remifentanil in the elderly. There have been a couple studies, although older, comparing some of our inhaled volatile anesthetics when elderly patients greater than 65 undergoing hip or knee replacement were compared desflurane versus sevoflurane. It's a little faster emergence and shorter PACU length of stay for desflurane, but cognitive impairment was pretty much similar between the two, and there's not a real strong benefit to choosing one over the other. When recovery from sevoflurane was compared to isoflurane and sevoflurane versus the gold standard of propofol, recovery was faster in sevo versus iso. Remember, its blood gas solubility is less sevo than iso, and you'd expect awakening times a little bit quicker. And the difference became greater when there was longer duration surgical cases and a longer time to orientation, but sevo always was a little bit faster than iso within any age group. When you compared sevo versus propofol, recovery times were equal between the two in elderly patients. So I think the take-home message from that is most of our drug dosages need to be decreased. We don't need as much volatile anesthetic. Choosing one over the other, sevo versus des, for example, probably not a great difference between the two. Sevo and des may have some advantages over isoflurane for awakening times. When you compare regional versus general in aged patients, you'll find tons of papers on this, but there's little, if any, difference in outcome, regional versus general, in the elderly patients. No difference in postoperative cognitive decline or delirium. Some possible benefits of regional that you should at least think about. Maybe decreased postoperative graft thrombosis and vascular surgery. Blood loss might be decreased with certain types of surgery. This has been looked at, for example, with hip surgery, hip replacement. Decreased postoperative deep venous thrombosis, and maybe a lower risk of postoperative hypoxemia. Possible benefits of regional versus general. When you start doing a regional and add on some sedation, those benefits of possibly favoring regional pretty much go away, and regional is equal to general with outcomes in the elderly. So some summary clinical points as we finish up here. 1, look at coexisting disease present in these elderly patients. Look at that more importantly than their exact age. Chronologic age versus biologic age, and advanced chronologic age is not a contraindication of surgery. Number 2, remember that there is physiologic decline in organs of the body, and mainly it's the functional reserve to meet perioperative stressors that is the real problem. They can't crank up the cardiac output. They can't crank up the minute ventilation like a younger patient when stressed. So organ reserve can be unpredictable and may only become apparent during severe stress, and you realize, boy, that wasn't that great of a stress, and they could not meet it. Functional reserve is decreased. There's going to be big inter-individual variability in the aged patient, and most of our drugs we should reduce the dose and increase the interval of dosing, more time in between. There's very little difference in outcome between general versus regional, and you can expect blood pressure lability in the elderly versus the young. Their sympathetic nervous system is increased, norepinephrine levels are up, there's greater swings in systemic vascular resistance, their baroreceptors and baroreflexes aren't as active, they can't increase their heart rate as much when they need to, the myocardium is often stiff and preload dependent with diastolic dysfunction. They may have some difficulty in the airway too, because their neck extension could be reduced, their mouth opening reduced, loss of protective reflexes, passive aspiration are risk, and some diseases like diabetes and rheumatoid arthritis can directly impact airway management. Number 8, when you're thinking about fluids, realize that excessive volume administration is not going to be well tolerated in the elderly. Their veins are stiff. There's going to be exaggerated increase in CVP per the volume that you give. The myocardium is stiff, and it's not going to be able to relax and accept the volume as well. It's diastolic dysfunction. And there's a perioperative risk of AFib. The left atrium is already often enlarged. You enlarge it a little more by giving a bunch of fluid, and AFib can occur. Avoid some drugs like scopolamine. That's going to really scramble up the brains of an elderly patient. And so probably not a wise choice for antiemetic strategies in an elderly patient. Benadryl, Demerol. Avoid as many drugs as you can. Limit the amount of drugs that you're given. Avoid polypharmacy. There's no particular transfusion triggers, but realize that the need for transfusion is individualized in that 7 to 10 hemoglobin range for someone who's young. Of course, we can let the hemoglobin go down a little bit lower. Older, with decreased delivery of tissue to the delivery of oxygen, that is, to the tissues, and ability to increase cardiac output, the trigger may be a little bit higher for transfusing an elderly patient. There's some postoperative unique problems. A postoperative cognitive decline and delirium, hypoxemia, and hypercarbia may be higher because of their inability to respond as much to hypoxemia and hypercarbia and the changes in closing capacity, for example. And we need to keep meticulous attention to detail to avoid minor complications, which in an elderly can rapidly escalate into a major adverse event. So in summary, when someone asks you what's the difference between elderly patients and young patients with anesthetic management, just remember that any anesthetic method or combination of anesthetics and methods that's serviceable and good at all is serviceable and good for old people in general. But the main difference is that these people are tender, are quieted easily with sedatives, are anesthetized and relaxed easily, and overdose readily. That came from Ralph Knight way back in 1954, and most of that holds true today. Thank you, and I hope you have a wonderful day.